Okay, so this is lecture 6 in foot and ankle trauma in our introduction foot and ankle course. This is where I come from, Heatherwood Hospital in Ascot, Northwest London. And again, it's the channels where you will find all the educational activities we're running, my YouTube channel, and also be my official channel. So to start with foot and ankle trauma, the most and the commonest hindfoot injury is the calcaneal injury. And the calcaneal fracture is a way and site of debate since ages. So early we were in a stage where every calcaneal fracture was operated. Skin problems and complications of wound healing and complications of post-traumatic arthritis were very, very high. So the people shift from that to go for conservative treatment, try to do a conservative treatment for every calcaneal fracture. Then came the HEAL trial at 2014, and then its follow-up in 2019, which gets us again to non-operative treatment, saying that non-operative treatment is comparable to operative treatment. Until the moment, there is no clear answer for the question, shall we fix a calcaneal fracture or not? So calcaneal fracture is a complex injury. It's, as you can see on the right side, it's an anatomically complex bone. It's not the simple bone, has a lot of curves, has a lot of surfaces, has a lot of articular facets, has a different articulation in different areas, has a lot of tendons and ligaments running behind and across it. And approach to it, the skin in this area, taking all the blood supply from perforators coming from the bone. And to do an extended approach for the calcaneum, you divide the skin from its own blood supply. And this where a lot of skin and wound problems come. So quick look on the anatomy, which will dictate our discussion about the calcaneum fracture, because of the anatomy of the calcaneum, post-traumatic arthritis is very high even with operative treatment, and because of the complex anatomy of the calcaneum, fixation of the calcaneal fracture isn't the easiest. So basically, the anatomy of the calcaneum, you have to hold the calcaneum in your hand to understand the triple curves of the calcaneum and the three facets. So basically, it has an anterior facet, middle facet, and posterior facet. And as we all know, the posterior facet, which makes the subtalar joint, is the biggest facet of them. Middle facet is anteromedial, where the subtalar tali is, and where part of the talar head rests on, and then the anterior facet, where the end of the talar head is there, and where the articulation with the cuboid happens. We all hear about the sinus tarsi, and you can see this is this is a sinus tarsi, and it's basically between the middle and posterior facet, and this where the intraosseous sulcus there. And when we have the tarsal canal from the talus coming on, this become the sinus tarsi, and this is what you can see here. So from a sinus tarsi, then the calcaneal groove, then come the talar sulcus and become the sinus tarsi, the common sinus tarsi, where the vessels, the lymphatics, and the nervous is running through. And as we understand, the main blood supply for the talus, which is the artery of the tarsal canal, which runs through this tarsal canal. Subtalar tali, the one here, is actually a dense bone, dense cortical bone, which where the talar head rests on, and the flexor hallucis longus runs underneath. And this is your backbone. This is where you will build all the fracture calcaneum fixation on. If you don't have a proper subtalar tali, or the subtalar tali goes, so fixation of the calcaneum is nearly impossible, because this is where you will build on when you are fixing a calcaneal fracture. So subtalar tali gives attachment to a lot of structures. It's underneath it, there's a flexor hallucis longus groove. It gives attachment to the superficial deltoid to the tibiocalcaneal part of the superficial deltoid, the talocalcaneal ligament in the interosseous ligament between talus and calcaneum, and definitely the spring ligament, the plantar calcaneal navicular ligament. And with a calcaneal fracture, you need to understand that because it's a weight-bearing bone, once you see a calcaneal fracture, you have to put your hand on the knee to exclude any tibial plateau fracture. You have to put your hand on the hip to exclude neck-of-femur fracture. You have to put your hand on the back to exclude any pelvic fracture or a spine fracture. So when we look at the calcaneal fracture, we basic investigation is to have an X-ray. And remember that you need for an X-ray of calcaneum at least lateral and axial or Harris view, so you can assess the calcaneum properly. And the most important for us from the calcaneum is where the calcaneum doing its job. For the calcaneum to maintain a normal subtalar joint, it has two angles maintained in normal range, which is the polar angle, the one you see here, where it's a line through the posterior cortex edges and a line through the posterior facet engine, and the line through the posterior facet and superior tuberosity. And this angle is normally 25 to 40 degrees. And this gives you an idea about the height of the calcaneum and the width of the calcaneum. If the height of the calcaneum is reduced, polar angle will be increasing or decreasing, and when the posterior facet is gone, polar angle will be abnormal. So when you see a flattened or decreased angle, you know that the posterior facet has collapsed. It means the height of the calcaneum has reduced and the subtalar joint is not normal anymore. When you come to angle of Ghissani, you have the angle of Ghissani. If you have a look, it's just the valgus angle, as you see here, between the two stops of the calcaneum, so the calcaneum superior surface. And this is a critical angle because it gives you the idea about the orientation of your posterior facet. If the posterior facet collapses, this angle will be increasing, going into more obtuse angle. And this again gives you an idea that your subtalar joint isn't normal anymore. So polar angle on the left side, and it's tangential line across the posterior facet and a tangential line from posterior facet to superior tuberosity, and it's maintained into 25 to 40 degrees. Once the posterior facet starts to collapse, height starts to reduce, polar angle will be decreasing. And on the other side, Ghissani angle is through the posterior facet, and as you see, it's an obtuse angle about 120 to 140. And when it increases, means the posterior facet is collapsing. And both of them reflects that the subtalar joint isn't congruent anymore, and this is where the post-traumatic arthritis will happen. With such a calcaneal fracture, as you can see, it's a lot of articular surface, so definitely it needs a CT to understand how much of the height, how much is varus or valgus heel, and how is the articular surface, our articular foci. So for us, if you decide about what you will do for the calcaneum, you need to know if the calcaneum is shortened or height is reduced or not, if the calcaneum is invarus or not, because putting it in invarus will disturb the distribution of the load during weight bearing, and this will accelerate the post-traumatic arthritis. Number 3, if you plan to fix it, you need to understand if the lateral wall is still intact or not, because if the lateral wall is gone, so you have to have a fixation. And lastly, you have to assess the articular foci to understand the interarticular element of it. So if we come to classify the calcaneum fracture, we have a descriptive classification, which we classify the calcaneum fracture into interarticular, extraarticular, and body fracture. Then we have the Essex laborosity classification, which is an old classification. The only importance of Essex laborosity is the tongue type fracture, and we'll come to this in a minute. Then now we have the CT-based classification, Sanders classification, which is a very important classification if you plan to fix the calcaneum, because it gives you an idea what you are fixing to what. So extraarticular fracture could be the tuberosity avulsion, could be the anterior process fracture, and could be the sustentaculum. So tuberosity avulsion is mostly with, it happens in direct trauma with forcible contraction of the triceps suri. Anterior process fracture is always with foot inversion injuries and lateral ligament rupture. So a patient with ankle sprain, you need to be very careful about the anterior process of the calcaneum, it has a fracture or not. Then the sustentaculum, and this is a bit of like significant trauma to cause the sustentaculum to break. Then body fracture, and this is what we will classify in a minute. An interarticular fracture, when there's a line running through the posterior facet, especially, we look after the posterior facet more than the middle and anterior facet, because as you understand, the posterior facet is the main component of the subtalar joint, where the arthritis and the symptoms will come from. Essex laborosity is looking into the primary fracture line, which extends from posteromedial to anterolateral. The importance of Essex laborosity is the tongue type fracture. And as you can see here, this is the tongue type fracture when the line extends from the posterior fossa going through the tuberosity, and this starts to avulse. If you're following me, you understand that this is attached to the Achilles tendon, so it always avulses up. And the problem is this fracture will be pressing on the skin and causing the skin to necrose and die. And this from where this fracture become an urgency. So you have to reduce this urgently, especially in vulnerable people, old age, diabetic patients, smokers. These people are prone to have skin problems. And if you leave a tongue-type fracture pressing on the skin, this will be determined with skin loss. Once you do that, you have to immobilize this patient in an implantar flexion because you have to relax the Achilles tendon so that there's no more ball on the tongue-type fracture. The other type of fracture is this one, which is the joint depression, and it's more commoner because as you understand, the commonest mechanism of injury in calcaneal fracture is fall from height or axial compression. So the joint depression type is very, very common. If we come to Sanders' classification, so Sanders has based his classification on axial view and coronal view of the CT, and it's looking into the posterior facet. And when you look in the posterior facet, you need to see how many fracture lines running through the posterior facet. And after that, you have to look where this fracture is running and then how much displacement. So in Sanders, you look into two views, coronal view and axial view. You need to answer three questions: how many fracture lines through the posterior facet, is they are displaced or not, and if there's more than one fracture line, where is it? So if you have any number of fracture lines which are undisplaced, this is type 1. If you have one fracture line with displacement, so two displaced fragments, is type 2. And if you have two fracture line with displacement, means 3 fragments, this is type 3. And definitely if you have more than this, it's comminuted type or type 4. And every type of them depends on where the primary fracture line is. If the primary fracture line is just in the middle of the fossa, so this is, in the lateral part of the fossa, this is A. If it's in the middle of the fossa, this is B. If it's medial to the posterior facet, this is C. And this means it goes through the subtalar, and this is the worst type. So again, when you look in Sanders, you have to have a CT. And Sanders, the main importance of Sanders is planning for operative treatment or planning of fixation. And Sanders has based his classification based on how many fracture line across the posterior facet and how displaced is these fractures. And number 3, where is the primary fracture line? So if you have any number of fracture lines but they are undisplaced, this is type 1. If you have one fracture line with 2 fragments displaced, this is the type 2. And if you have 2 fracture line with 3 fragments displaced, this is type 3. And more than this is a comminuted type or type 4. Based on the primary fracture line, if it's lateral in the posterior facet, means it's away from the sustentaculum, means I'm still having a good sustentaculum base to hold in my fixation, is A. And if it's in the middle of the facet, is B. And if it's across the sustentaculum or medial, is C. And this is the worst type because I don't have any sustentaculum anymore to reconstruct on. When we treat the calcaneal fracture, as we agreed, has a high risk of skin problems and soft tissue problems. So once you see this patient needs to have, never ever put this patient in a plaster. This patient needs to go in just wall and crib. Keep this patient strictly elevated on a primary frame and or pillows or whatever what you use for elevation. And then the patient needs to be continuously on ice. And this is the situation until the soft tissue settles. And normally this takes up to 5 days to a week. There is no plasters anymore, long time ago, but I know that still some institutions, schools is doing a plaster. No plaster anymore, wall and crib, proper elevation on a primary frame or pillows and ice. Your soft tissue will dictate the time you will do the operation. So if you're planning for operative treatment, so the soft tissue is the first dictator because the main problem is infection and skin condition problem or skin wound problems. So never ever to operate on a patient without a proper soft tissue cover. Never ever operate on a patient with soft tissue which is still edematous, injurious, and liable for problems. Will I operate or not? As we agreed, there is the evidence says the main evidence quote right now is the UK Hale trial or UK Hale fracture trial, and this has looked into 200 something patients over 2 years. Firstly at 2014, their follow-up of 5 years follow-up at 2019, and it has been published 2021. And they found that there is no symptomatic or functional advantage of operative over non-operative after 5 years. to be honest with you, is not that strong evidence to follow. It has a lot of biases in selection, biases, randomization biases, a lot of biases. It hasn't included main cofactors in the treatment, like if the patient is a smoker or not, age of the patient, type of fixation, level of expertise of the surgeon who fixed the fracture. So it's so difficult to depend on it. But this is one of the robust evidence in our hand. But you need to understand before you take your decision that you cannot depend on the HEAL trial alone to take a decision to operate or not. So HEAL trial, as you can see, give you a clear statement that there is no symptomatic or functional advantage to operative over non-operative. If I have a young patient who is non-smoker and operated by a proper surgeon, and another patient who is a smoker, who is diabetic, who has have a poor fixation, I cannot put both of them in two lines to compare, because there is a lot of co-founding and cofactors, which makes a lot of bias in this choice and this decision. So we have another evidence in 2002 from Canada. It's an RCT comparing operative versus non-operative, and they found that the functional outcomes are equivalent, but patients with work compensation do poor with the non-operative treatment, and they aim to an operation. So it's another evidence supporting non-operative over operative. Practically, from the experience I have, so calcaneal fraction always doesn't do well, to be honest. So operative versus non-operative may differ in the time when the arthritis will happen, but both of them will have post-traumatic arthritis at some stage. In my practice, I keep the calcaneal fracture fixation to a reliable patient, young age, who has varus or loss of height or plumb lateral wall. Other than this, non-operative treatment will give you nearly the same results with just an early arthritis rather than late arthritis in post-traumatic arthritis in operative group. So practically, if you come to the practice, you will not make a huge difference for calcaneal fractures outcomes with operation, except in a young patient with varus heel or loss of height or plumb lateral wall. So you have to select your patient. You have to be sure what you are doing for the patient. You have to have a good conversation with the patient, explaining them the best evidence available and the options of treatment, pros and cons of each, because he needs to understand that the operation isn't a magic. It's a magic, and it will not make a magic results, but the results are nearly comparable functionally, because both options will end by post-traumatic arthritis. The difference is when, and a failed fixation or a poor fixation is much worse than non-operative. So because of that, calcaneal fracture management still doesn't have a fixed, clear answer. So if you opted to operate on this patient and fix the calcaneal fracture, the one which carries an urgency is the tongue type, as we agreed, because you have to decompress the posterior skin, especially if the patient is vulnerable, like an old age, diabetic, poor skin condition, smoker. And when you do that, as we agreed, you have to reduce it. You can stick two screws across it percutaneously or openly. Your problem with the percutaneous is that sometimes the periosteum is just into the fracture site, and you have to clear that before you reduce the tongue type. Other than this, you operate on a patient with a wide hindfoot to avoid the subfibular impingement and peroneal impingement. Patient with hindfoot varus, because as I told you, this means altered mechanics. It alters the mechanical axis and put the patient at higher risk of getting a post-traumatic arthritis very early. Try to avoid this in smokers and diabetic, because they don't do well after the operation, and as we agreed, failed or poor outcome or poor operative results has much more determinant outcomes than non-operative. So any smoker or diabetic, you know that the operative results will not be good, and non-operative treatment will not make it any worse. So you have to speak to your patient honestly, explaining what can you do for him, what can you achieve. If he's a smoker or diabetic, there is not a lot you can achieve with operative treatment. So you have to be honest with your patient that non-operative will nearly give the same results as operative in such type of patients. So if you're planning to operate, this is two patients of mine. You can see you have two options of regarding the surgical approach. Either you do an extended Atkins approach. An Atkins approach, as you can see on the right side, you mark your lateral mal, you mark base of fifths, and then you go into the demarcation line between the heel skin and the normal skin. Make your this is the Achilles, this is the demarcation, and you go as over the angle, just you feel the bone, and you just go over the ankle as far as you can, because you need to elevate a very big flap here to avoid skin necrosis and skin and wound problems later on. Be careful, your sural nerve is just under my cursor here, so it will be coming in your way while you are dissecting. Remember that you need, once you open the approach, you need to go across the whole soft tissue to the bone, so your knife needs to go up to the bone before you do anything. And when you elevate, you have to elevate a full flap, so the elevation has to be from the periosteum. It's not allowed to be keeping any soft tissue over the bone, because the more you have, the thicker flap you have, the more this flap will live, because poor blood supply coming mainly from the periosteum. So if you keep enough soft tissue flap, this will be will give you a better results regarding the wound problems and skin problems. Once you do that, you can hold this flap with a suture or a wire or whatever you are doing. Then your point here is you have to go and try as much as you can to plan your fixation. You have to start botting on the sus tentaculum tilai. Sus tentaculum tilai is your cornerstone. Start from sus tentaculum tilai and start to build up on it, and reduce as much as you can in a staged manner. So if I have a blown lateral wall, I get the lateral wall open, I see the main fragments, I try to stick the main fragment to the sus tentaculum, hold it with wire, and build up on it with the small fragments until I have a well-shaped calcaneum. Then I buttress it with a calcaneal plate from outside. The calcaneal plate, thankfully, these days are thin, low profile, so they don't cause a lot of problem on irritation, and they have a lot of screws, VA screws with multiple options, which allow you to play with different fragments and get them back to the sus tentaculum. I always start with a couple of cannulated screws through the main fragment to the sus tentaculum separately away from the plate. Stick the plate on once I reduce all the fragments, and maintain the lateral wall supported with the plate, and then get my closure. As you can see, is if you're doing from the lateral wall, and you can see that if the fracture has involved the perineal tubercle, you can do some Z-plasty for the perineae, and then you can repair them after the fixation. So if the other option, which is getting more popularity these days, is the sinus tarsi approach. Is a limited approach and give you an access to most of it. So basically, you go from the tip of the lateral malleolus across along the fourth ray. So you hold the fourth ray in your hand. You see the fourth ray, where the fourth ray is, and you just open a sinus tarsi approach from the tip of the lateral malleolus across the fourth line with the fourth ray. It's mini open, as you can see, a small incision, and then when you go in, you just go between the perineae, the perineae on the plantar side and the ADL on the dorsal side. Once you go in, you will find your EDB in the way. You have to elevate the EDB from its origin, and then you go in, and you can see the subtalar joint here, and then the calcaneum, which you can manipulate and play with, same as you do with the extended lateral. The only difference is you need to be it needs some learning curve. You need to know how to reduce the fragments. And the idea of the sinus tarsi that we found at the end of the day, the maximum you can do with operative treatment is to restore the height, to restore the articular surface. From the sinus tarsi approach, restoration of the articular surface is very possible. And then from outside, you can joystick to restore the height before you do a fixation. It definitely needs a specific instrumentation and needs a specific plating when you do that. So methods of fixation from either approach you use, either low profile lateral calcaneal plate, and there is dozen of options of lateral calcaneal plate in the market at the moment, and most of them are doing the job very well. I use the synthesis plate mainly, and they are doing a very good job. Then if you have the tongue type, you have the option to do a percutaneous 2-lag screws after you manipulate it with some key wires and hold it with some key wires. At some point, your option may be, if you opt for operative treatment, is to do a primary subtalar arthrodesis when it's horrible comminution, Sanders type 3 or 4, and there is no option to restore the posterior facet. So what you do a minimal open reduction tendon fixation to restore the height and to correct the flat bohler, and then you go after restoring the height and do a primary fusion of the subtalar joint. And honestly, the results of this are very, very consistent and good. So what the complication with a calcaneal fracture? As we agreed that the surgical outcome will depend on how many fragments you have, especially intra-articular, and how is the quality of the articular reduction, because we know that post-traumatic arthritis is the end of the outcomes. But how, if you reduce your fracture as well, if you restore the articular surface properly, you have a congruent articular surface, you make this a bit late. Subtalar arthritis is the most common inevitable complication, which will need subtalar fusion at some point. Wound adhesions and infection, they are more and more common complication with surgical option, about 15%, and this is a huge number to have a 15% wound complication after surgery. And the patient will reflect on the infection as a night pain. Varus malrotation, malunion, and this varus malunion is very, very common, to be honest with you. And the option you have for that, once it happens, that to do a corrective osteotomy and release or lengthening of the Achilles tendon. FHL damage, especially if you put long screws which bust across, as we agreed, the cornerstone of your reduction and fixation is the sustentaculum, and just underneath the sustentaculum the FHL runs. So if your screws are long, from the lateral side, they will end by pointing on the medial side and injuring the FHL. From your approach, if you're doing an extended lateral, there is a high risk to injure the sural nerve, and definitely if you miss the tongue type, you will end up by Achilles tendon shortening and inefficiency. We're done with the calcaneum, then we move now to the talus. And when we speak about the tail and neck fractures, the good thing, thankfully, they are not a day-to-day fracture presentation, not a day-to-day cases in the emergency department everywhere. It's always happened because of forced ankle dorsiflexion when the talar neck starts to impact on the anterior distal tibia and end by fracture of the talar neck. Why we speak about the talar neck? Because if you remember with me the anatomy and how the talar bone appears, so you understand there is a body, and from the body two processes comes out, and then the neck is just coming out into an angle connecting the head with the body. The second thing is we understand that all blood supply of the talus is retrograde, coming across the neck. So with neck fracture, the blood supply to the body is affected, and this another importance, which that's why we speak about the talar neck fracture as a single or a separate entity. We classify it as by Hawkins, as all of us know. So Hawkins, the point of Hawkins is it quantify the risk of AVN. So it started from non-displaced fracture with AVN of risk of about 15 to 20%. Number two is displaced fracture with subtalar dislocation, and this carries a risk of about 4% AVN. Then subtalar dislocation with tibiotalar or ankle dislocation, which has an AVN of 60 to 100%, and end by dislocation from talonavicular joint, and this carries a risk of 80 to 100% AVN. Hawkins is very good in detecting the AVN. It doesn't affect a lot the way of management or a way of reduction, but it can guide you through. So if it's undisplaced fracture or Hawkins type 1, the patient will need non-weight bearing and cast for 8 weeks, and then start putting some weight on, so treating nearly non-operative. If the patient have only subtalar dislocation, so you can reduce that and put the patient into a cast. But nowadays we operate on all these cases because the risk of EVN is low with operative treatment. Then if the patient is a subtalar and tibiotalar dislocation, definitely we need an open reduction and tendon fixation. The most important at that stage is the soft tissue. You need to look after the soft tissue. These injuries will come to you mostly as an open fracture dislocation. So you have to look after the soft tissue. And definitely if Hawkins 4, you cannot promise this patient for more. It's an AVN risk of 80 to 100%. So whatever you do for the patient may end by an AVN. If we Want to look into a talar neck fracture, we have the canal view. As you can see, you plantar flex the foot, you moved into 15 degrees internal rotation, and your beam is moved cranially by about 75 degrees or 15 degrees caudally if you are doing a perpendicular beam. This is where the positioning of the patient is. You have this lock, and when you do a canal view, you can easily see the whole talus, including the talar neck. The most important when you look in an X-ray of a talar neck fracture is to identify Hawkins sign if it's there. And Hawkins sign, basically, as you can see here, is a subchondral radiolucent band, and this gives you an idea that this area is starting to revascularize. Because of revascularization, this stimulates the osteoclast, and the osteoclast makes some osteopenia to start with. And when you see this osteopenia or radiolucent line, you need to understand that this area is starting to revascularize. So actually, Hawkins sign is a good sign. When you see Hawkins sign, it's not because of the vascularity is disrupted, but actually because of revascularization has started. And if you don't have Hawkins sign after a fracture or non-operative treatment or fixation, if you lack Hawkins sign and you have sclerosis, you have to know that your patient is going into EVN. Definitely CT is needed for talar neck fractures, especially if you cannot spot it from the X-ray. So how will we treat a talar neck fracture? When you deal with a talar neck fracture, you need to understand that approaching the talus isn't easy. As I told you, the talus is not just a straight bone. It's the body and a varus angled neck on top of it, ending by a head. That's why you always need to go through two approaches. You need, firstly, as you can see on the right side, you need to be sure that your soft tissue will allow you to do that. And as I told you, from Hawkins 3 and Hawkins 4, they are commonly to come as an open fractures. So if they come an open fracture, they need an urgent reduction, and once urgent reduction, stabilization with some K-wires or X-fix or whatever you have until soft tissue settles, and then you go and fix it. When you fix it, you will fix it from dual approach, anteromedial and anterolateral approach. As you can see on this side, the anteromedial approach is just between the medial malleus, as you can, if you draw the medial malleus and navicular tuberosity, and you just go between the tibialis anterior and tibialis posterior. So when you go between tip ant and tip post, you will be on the talar neck straight away. You need to be careful, and you need to be mainly careful about the deltoid ligament, because the deltoid ligament, if you open here, the precursor, yeah. So medial mal, tip ant, and you go between the tip ant and tip post here, and once you go here, the deltoid ligament will be just underneath here. So you be careful about not to injure the deltoid ligament, especially you know that the deltoid ligament carries the blood supply to the talus, and your blood supply, the tarsal artery, the artery of the tarsal canal, which is coming here just underneath the deltoid ligament. If you need to go more than this, if you need to deal with a talar body fracture or a very, very posterior talar neck fracture, you may need to do a medial malleolar osteotomy. So it gives you an approach to the medial side of the subtalar joint. Coming to the earlier approach of the anterolateral, as you can see, sorry, the picture on the other side. Same like the sinus tarsi approach, in line with the fourth ray, and you go here between the Bernier and Bernays tertius and EDL. And once you go between Bernays tertius EDL and the Bernier and Bernays tertius and EDL, you expose the subtalar joint, the talonavicular joint, and the calcaneal cuboid joint. It's quite a very good approach. So basically, lateral mal, you go from the tip or anterior. In talar neck fracture, you go from anterior end of the lateral mal. In the calcaneal fracture, you go more plantarly, so you go from the tip of the lateral mal to the fourth ray. In line with the fourth ray, you open your approach. Bernays tertius and EDL will be on this side. Bernays brevis will be on this side. Once you go in, you need to, if you're dealing with this area, that's fine. If not, you need to get the ADB off its origin, and then you do whatever you want. So once you reduce the fracture site from dual approach, you have a lot of options to fix this fracture. So mostly use a cannulated screws, or you do a bilateral plating. This depends on how much comminuted is the fracture. So if your fracture is just a transverse or oblique line, you can easily stick two screws either from anteroposterior to or posterior anterior. Both of them will do the job. nowadays we're running more towards plating, so we plate mostly medial plate or medial lateral plate, so we can give a more support, especially if it's a comminuted fracture or a poor porotic bone. We try to use titanium because to follow up the AVN, you will need frequent and follow-ups MRI scans, and if you use a stainless steel implant, it will be difficult to have an MRI scan. Complication of talar neck fracture, again, we understand the most common complication, and this is a very common question in the exam. It's not the AVN. We have spoken about the AVN. Hawkins has built his classification based on AVN risk, but still subtalar arthritis is the most common complication. And this is a very common MCQ question. What's the most common complication of post-talar neck fracture? It's not AVN, though AVN is very high, as we agreed in Hawkins 3 or 4, it goes up to 80 to 100%, but still subtalar arthritis are more commoner. For the AVN, you have to follow the patient for 2 years, especially Hawkins will appear within 6 weeks to 3 months. Then you have to follow the patient because we don't know how the revascularization, how the bone will behave, will it collapse or not. So if a patient is at risk of AVN, you have to follow this patient for 2 years at least. Varus malunion is again a precipitating factor for subtalar arthritis, because if you lose or decrease the subtalar eversion, you impinging the talar neck, and this will put abnormal mechanics on the subtalar and end by arthritis. Subtalar dislocation, very common entity and very common association with talar neck fracture. As we told, subtalar dislocation is Hawkins 2. And you have subtalar dislocation either from lateral side or from medial side. It's commoner to be from the medial side because basically the neck is normally is in varus, and the commonest to happen with this is inversion injuries. And with inversion injuries, the subtalar dislocation is commonly to happen medially. Associated fracture, if it goes medially, will be either dorsomedial talar head fracture, medial mal, posterior talus, or navicular. If it goes laterally, will be injuring the cuboid, the anterior posterior of the calcaneum, or the fibula. Basically, as we agreed, is the medial supination would be in an inversion, which is supination in definition, and the lateral dislocation was happening with pronation, which is eversion. The most common question in this area is what is blocking the reduction. So he give you a case coming with a medial dislocated subtalar joint, and the patient and the reduction is blocked under closed reduction is blocked under sedation or under general anesthesia. What's the commonest structure blocking the reduction in lateral dislocation? It will be the posterior tibial tendon. So when you have a posterior tibial tendon the posterior tibial tendon engulfed inside the dislocation, it will be difficult to reduce the lateral dislocation. And on the medial side, the commonest is the extensor digitorum brevis muscle. So if you got an exam question asking you what is blocking a lateral dislocation from closed reduction, lateral dislocation subtalar from closed reduction, it is the peroneus, it is tibialis posterior tendon. What's blocking the medial dislocation from closed reduction? It is the extensor digitorum brevis muscle. To reduce the subtalar dislocation, you basically need to bend the knee, release the Achilles, because this is the main driving force for plantar flexion. Once you release the Achilles, it will give you an option to reduce it unless either tibialis posterior is blocking if it's a lateral dislocation, or extensor digitorum brevis is blocking if it's a medial dislocation. As I told you, commonly these dislocations comes with an open injury or open fracture. So you need to do to follow the protocol, post guidelines for open dislocation, do wound care, reduce temporarily both key wires until the soft tissue heals, or plastics do some cover for it, and then you go for definitive fixation for what fracture you have. The other injury which can come to the talus rather than the body and neck fractures and subtalar dislocation is the osteochondral lesion. An osteochondral lesion of the talus is not uncommon, it's very common, especially for patients with recurrent ankle sprain. So if you see in your clinic a patient with hypermobility, recurrent ankle sprains for any reason, malalignment, tarsal coalition, flat foot, cavus foot, and they have recurrent ankle sprains, and they start to have a pain into the joint, you have to think about osteochondral lesion, osteochondral injury to the talus. An MRI scan is a must in this stage. They may come The commonest is to come into the shoulder, or what he call here the dome, but we call it the shoulder, and it's either medial shoulder or lateral shoulder. So the medial shoulder, because as I told you, the commonest is to have a inversion or a lateral ankle sprain. It's commonly to have a lateral talar dome injury. And if you have a lateral, this is mostly come in a traumatic history. It's always superficial and smaller, but the problem, they are always central or anterior, and they take time to heal with microfracture. On the other side, the medial dome injuries is commonly to be atraumatic, commonly to happen from avascular necrosis or OECD or whatever, and they are more commoner. The problem is you cannot reach it easily by anterior scoping. You may need a posterior scope to reach it, and they always large and deep and displaces. So again, we speak about the osteochondral injuries to the talus because they are very common, especially with ankle sprains. With ankle sprains, because an inversion injury is commoner to have a lateral dome injury. Lateral dome is always small and superficial, but it behaves very poorly and takes time to heal, especially if you just do a microfracture or you do nothing for it. Medial dome is always pathological, it's not always traumatic, it's more commoner, and when it happens, it's more posterior, and that makes it difficult to reach through an anterior scopy, and you may need to do a posterior scope. Brent and Harty has classified it into just bone compression or just subchondral fracture with bone edema, but still the articular surface is maintained. Number 2 is if the fragments start to be partially detached. Number 3, if it's become completely detached but still in place. Number 4, if it's completely detached and start to move from place. Number 5, if become cyst information, means there is poor bed underneath the fragment, so even if you reduce and fix it, it will behave very poorly and will not heal. So again, if we speak about Brent and Harty classification, it's number 1 on displays such a bone edema, subchondral fracture or bone compression. Number 2 is just partially detached. Number 3, fully detached but hasn't displaced. Type 4 has detached and displaced. Type 5, if become a cyst formation underneath it, which means poor bed for healing, and that's why even if you fix it and reduce it and fix it, it will never go back to normal. So the options you have for that, if you just have a small fragment which is displaced, you can do just a fragment excision and microfracture. The main and the golden line of treatment is microfracture, and these patients always behave well with a microfracture. If more than a centimeter, you may need to reduce it and fix it with a headless screw or pins or something. If the other option, if you have a big defect, and you cannot cover it, or microfracture didn't do well, you have the option of doing OTS, which is osteochondral autologous transfer system. You get the same osteochondral fragment from the knee, from a non-weight bearing area in the knee, and you just insert it into the osteochondral defect in the talus. Or you have to do a mosaicoplasty when you go to the interchondral notch in the knee or non-weight bearing area of the talus, and you just take a chondral flap and put this chondral flap or mosaicoplasty to cover the defect in the chondral surface of the talus. We go forward. So after the talus, the navicular fracture, and navicular fracture is very simple. Fortunately, it's not that common. So it may happen traumatic or a stress fracture. You understand that the navicular is under a lot of stress. Direction of the talus, the various direction of the talar neck and talar head, and the position of the navicular covering all the talar head under continuous tension from the tibialis posterior and tibialis anterior tendons. So it's commonly to have a stress fracture, and the problem with if the stress fracture happens, is very prone to non-union, especially it is doesn't have that good blood supply. Then the other traumatic fractures, if you have a traumatic fracture, will be either just avulsion from the head or from the body, or avulsion of the tuberosity, avulsion from part of the head at the attachment of the ligaments, or will be a body fracture, which goes into 3 types: type 1 undisplaced, type 2 displaced, and type 3 comminuted. So dealing with the navicular fracture, all what you need is just high index of suspicion. So when you see a patient with an inversion injury who is having pain on the midfoot, you have to look into his X-ray properly to exclude if he has a navicular undisplaced navicular or subtle navicular fracture. Especially, it's so difficult for you to see the navicular completely in one plane of X-ray. To see the navicular completely, you need a 3D format, because if you understand the shape of the navicular, so this is the talar head, and this is a navicular, and the navicular is extending in two planes, up and down, medial and lateral. So it's a big concave bone, which you can easily miss a subtle fracture on normal X-ray. Number two, you need to understand how to differentiate between bipartite or what's called accessory navicular and actual fracture. And definitely the accessory navicular or bipartite will be having a corticated end or a sclerotic end. It doesn't appear as like a fracture, and the patient will have this from before, so will be having some prominence in the midfoot rather than just appearing after the fracture. Then the fractures will be either avulsion, as I told you, avulsion from the tuberosity where the tibialis posterior attaches and the deltoid, superficial deltoid attaches, and or avulsion from the body where the interosseous ligament attaches, or after that, body fracture which may be undisplaced, displaced, or comminuted. So how will we treat this? Is commonly to be treated non-operatively. So all what you need is just to rest the patient in a boot, relax the tendon, doesn't allow the tendon to do any stress over the fracture. And if it displaced, especially body fracture, because this is by definition an intra-articular fracture, so you have to fix it. How we fix it? We go from the same anteromedial approach we went a minute ago through to the talar neck. So from anteromedial approach, you go between the tib ant and tib post, and just you open reduction and internally fix it either by a lag screw or by a dorsal plate. Dorsal plate now is very, very nice. You can use it very easily, low profile, and it has different shape which cover whatever the configuration or pattern of fracture, and adapt this easily to the body of the navicular. To remove it at some point, because as you understand, it's with the time start the healing happen. It's stiff the midfoot. This is where the medial arch, the medial longitudinal arch apex. So there will be a lot of stress on it, and you don't need the blade to cause any stress shielding and keep this navicular weak for fracture. So you need to remove it once the fracture union happens. If it's badly comminuted and there is no, it's not amenable for any fixation, so the option is to do a tenonavicular arthrodesis. The problem from navicular fracture, if you miss it, is a high risk of EVN because, as I told you, it's a watershed area with poor blood supply. And number two is cause arthritis of the tenonavicular, which is very painful for the patient during gait, especially during flat foot or loading phase. The commonest missed injury in this area is the Lisfranc injury, and it's very, very commonly missed because it's not easily to spot on the X-ray. Needs either a proper weight-bearing X-ray, CT, or even MRI scan. So Lisfranc is the commonest foot and ankle injury to be missed in the ED. So if we understand the Lisfranc injury or the Lisfranc joint to start with, so the foot has three columns. So for descriptive purposes, we say that the foot has a medial column, which is formed by a first ray, and this is considerably stiff. It still have some movement, but considerably stiff. The movement in this ray is about 4 to 5 degrees. Then the foot has a middle column, which is the second and third TMT, or the second and third ray, and this is the most stiffer or the least mobile, and this is important for the rigidity during the two-off to make the foot a rigid lever. Then you have the lateral column, which is very mobile. This is the fourth and fifth ray, and this you use to for your foot to accommodate the uneven surface or uneven ground. So basically, for description, the foot has three columns: medial, middle, and lateral. Medial column is the first ray, and this has some degree of movement, and this some degree of movement, about 4 to 5 degrees. Then has a stiff mid column, which give it the lever, make it a lever for two-off during the gait, and then a lateral column, which is mobile to accommodate the uneven ground or uneven surface. This is the fourth and fifth ray. Stability of the midfoot or the transverse arch is depending mainly on the middle, on the second ray or the stiff ray or the middle column. So to understand the ligament, the Lisfranc ligament, so the Lisfranc is maintained in place by mainly four ligaments. The most important is the Lisfranc ligament, which is running from the medial cuneiform to the base of second metatarsal. Then you have the plantar and dorsal tarsometatarsal ligament. The dorsal is the weaker. That's why it's common if the Lisfranc injury happens for the base of second metatarsal to just jump up. So on the lateral X-ray, you have to spot if this is a dorsal subluxation or not. And why a dorsal subluxation? Because the plantar interosseous ligament is much stronger, or I'm sorry, tarsometatarsal ligament is much stronger than the dorsal one. Because the dorsal tarsometatarsal ligament is weaker, it's more commonly for the metatarsal base to jump up or to dorsally sublux. Then you have the intermetatarsal ligament, and then you have the interosseous ligament. So it's basically tarsometatarsal, and this is our dorsal and plantar, and the dorsal is weaker and the plantar is stronger. Lisfranc ligament, which goes from the base of second metatarsal to the medial cuneiform, intermetatarsal between the metatarsals, and interosseous between the cuneiform bones. As I told you, this is the joint at this area are from minimally mobile in the first TMT to a very stiff second and third TMT joints, and this is very important for your gait. So how you get a Lisfranc injury? The most common is fall, is direct crush injury or fall on a plantar-flexed foot. When you fall on a plantar-flexed foot, all the trauma or all the force goes across your middle column, and this is where the Lisfranc happens. Then the other way of injuring it is the torsional force, because when you move the foot into torsion, the mobile columns are safe, but the stiff columns are very prone to have an injury. That's why Lisfranc injury happen either from fall on the foot in a plantar flexed position or torsional forces over the foot. To classify it very easily, it's either isolated ray, so like first ray displaced and the lateral four rays in place, or either it's a homolateral, means all the metatarsals at the tarsometatarsal level went in one way, or diversion means the first ray went in a way and the lateral rays went in another way. So either the four lateral rays are in place and the first ray only displaced, then this is called isolated, or either both of them go in a different ways called diversion, or all of them go in the same way, which is called homolateral. When you examine this patient, you need, once you concentrate on the mechanism of injury, you need to have a high index of suspicion and suspect a Lisfranc injury once you hear that the patient either fell on a plantar foot or has a torsional injury to the foot. You have to look into plantar ecchymosis. Is a very pathognomonic sign for Lisfranc injury, and definitely you have to check for compartment, because this is the area where the central compartments of the foot is, and very common to have this compartment syndrome. And if you have a compartment syndrome and you miss it, this will end by the patient having no intrinsic power and intrinsic weakness and contraction, and this will end by a closed tooth. When you have an X-ray, it has to have a weight-bearing X-ray, because you need to stress the foot to see if it's a ligamentous injury with no bony injury. You will not see the ligamentous injury until you put the patient on a weight-bearing foot. And the problem with weight-bearing X-ray is that the patient is in a lot of pain, and sometimes he doesn't put all his weight on the foot because it's painful for him. So you need to be sure that the patient has had a weight-bearing X-rays to judge on it. Without a proper weight-bearing X-rays, you will not be able to judge on a Lisfranc, and that's why it's very commonly missed in the ED. What you're looking after in the X-ray. So when you after in the X-ray a flex sign, which show an avulsion fracture for the Lisfranc ligament from the base of second metatarsal, as the one here. So because, as we agreed, the most strong in the interosseous Lisfranc ligament, which goes from medial cuneiform to base of second, and when this is stressed, it avulses a piece of bone from the second metatarsal base, and this is what we call the flex sign. Number two, you have to look into the separation or diastasis or widening between the first ray and the second ray, which this is definitely abnormal. And when you look into an EB, you have to look into the congruity between the medial border of the second and the intermediate cuneiform. And when you look into an oblique X-ray, you need to see the congruity between the medial border of the fourth metatarsal with the medial border of the cuboid. And lastly, when you look into a lateral X-ray, you need to ensure there is no dorsal subluxation of base of second. So again, weight-bearing X-ray, and you need to be sure that your patient has weight bear on his foot when he had the X-ray, because very commonly the Lisfranc missed because patient doesn't put a lot of weight on this foot because it's painful. Though it is marked as a weight-bearing X-ray, it's not actually weight-bearing. And you need to be after a flex sign which will be here from avulsion of the Lisfranc ligament from the base of second metatarsal. You need to look into separation or diastasis between the first and second ray. You need to look into how congruent is the second ray or the second metatarsal medial border with the medial border of intermediate cuneiform, and then how much congruent is the medial border of the fourth ray with the medial border of the cuboid on an oblique X-ray. And lastly, you need to see if there is any dorsal subluxation of base of second metatarsal. And then once you suspect Lisfranc, you have to have a CT scan. You have to have a CT scan. And CT scan will be showing you this is to you more and more. If you have the facility to have an MRI scan in the emergency to look into a ligamentous injury, if there is no bony injury and your clinical diagnosis is definitely Lisfranc, you can go for an MRI scan to assess the ligamentous injury. So how will we treat a Lisfranc? So Lisfranc is, as I told you, it's a missed injury. It's a very risky injury to keep the patient with chronic foot pain forever. So you try your best when you're doing an ED duty or you are seeing the patient as a first point of contact to not to miss a Lisfranc injury. So have a very, very high index of suspicion. Once you see a foot injury with plantar ecchymosis, mode of trauma is either torsional or falling on plantar flexed foot. Suspect Lisfranc until proven otherwise. Get CT scan, and if you have the option, get an MRI scan. That's why Lisfranc injury is always treated operatively. We don't treat non-operatively unless there is definitely no displacement or on a proper weight-bearing X-ray and stress views. And if we will operate, the operation is number one, we have to respect the soft tissue, ensure that the soft tissue allows us to go and internally fix it. And your aim from fixing is to have a stable construct for every ray. You have to get the stiffness back to the medial and middle column, and then you have to maintain the relation between, or to restore the relation between the medial column, which is the first ray, and the middle column, which is the second, third ray. So what you normally do, so a lot of debate about either you go and open and fix it or to fuse it or arthrodese it. A lot of schools and a lot of evidence support that you go and do a bridging plating, and a lot of schools supporting that you go and do a primer arthrodesis. Every team has its own rationale and own valid points. So the people who supporting that you do an open reduction internal fixation, they go that this is if it's a bony injury, it's very, very understandable. For a bony injury, you never go and fuse from the start. And it's always this frank injury in an active patient with young age, and it's unfair for a supple joint and a good articular surface to go and fuse it primarily. On the other hand, the people with arthrodesis, people supporting arthrodesis, their idea or their rationale is when you do a bridging plating, so you're looking for a degree of stability. So you're basically doing an arthrodesis by some degree. And as we agreed from the start from the anatomy that these columns are already stiff. So the people who are supporting the arthrodesis, they look into this and saying these columns are already stiff, and we're aiming from fixation to make them stiff again. So why not to fuse them from the start? So this is the rationale behind fixation and the rationale behind arthrodesis. What you will decide in my practice, we normally arthrodese any patient with ligamentous injury, and we normally, especially if it's young, and we normally fix every patient with bony injury, especially if it's old. Again, so open reduction internal fixation versus primary arthrodesis of midfoot. Open reduction internal fixation group support their idea by that this patient mostly inactive, young, so it's unfair to go in a supple joint to go and fuse it as a primary operation, especially if it is a bony injury. For the arthrodesis, they speak about that these joints are already stiff from the start, anatomically stiff, and we're trying to get them stiff again. So if the patient, especially if the patient have a ligamentous injury, better to go and fuse it as primary fusion. So, and my practical point is if you have a young patient with ligamentous injury, it's more safer to go and fuse it as a primary arthrodesis. If you have an old patient or a patient with bony injury, it's better to bridge it or fix it until it heals. So if you go for open reduction internal fixation, your approach will be either first or second web space according to how many rays injury do you have. If you have a first ray injury, you have to go from first either medial dorsomedial approach or first web space approach. Go into the first TMT joint, bridge it with a plate, either one plate from dorsal or one plate dorsal and one plate medial. If it's very unstable, then you go and fix the second ray, and then you put a screw across at the site, anatomical site of Lisfranc ligament, to restore the relation between the anterior, the first and the second ray. So my approach is I always go in the second web space between the second and third metatarsal. Approach from one side across the tendon, keep the tendon in the middle. Approach the second TMT joint from one side from the medial side of the tendon. Fix it in place. Bridge it with a plate, in a strong plate. Then go for the third. Fix it with a plate if I need to fix it. Then after that, if I'm happy with the first ray, I just bust a screw across the Lisfranc ligament anatomical side from the base of second metatarsal to the medial cuneiform. If I'm worried about the first ray, I assess the first ray always intraoperative for every case. But if I'm worried intraoperative, or I already diagnosed a first ray injury before I go into the operation, I will start my operation in the second web space, bridging the second TMT joint, maintaining the second ray, go medially, dorsomedial, fix the first ray, and then once I have two stable rays, I bolt them together with a screw, either from medial cuneiform to base of second, or from base of second to medial cuneiform if I'm opening to incision. So if I'm happy with the first ray, intraoperatively is stable, and I'm just doing the second and third ray, I go to the second ray, bridges the second TMT joint, and at that time, I bust my screw from the base of second metatarsal to the medial cuneiform. If I'm worried about the first ray, I go to the first ray, fix the first ray, and I have the two options, either to bust the screw from medial cuneiform to second, or from base of second to medial cuneiform. Will you need to remove this screw or not? A lot of debate, but to be honest, in my practice, I still remove the metal work after 6 months. A lot of schools now, they don't remove it until the metal work cause any irritation to the patient. Both options are valid, but my practice is I remove the plates and screws in 6 months. If you come to the metatarsal and toe trauma quickly, so I'll just spot the important fractures to come in the exam. You know definitely the march fracture, which is common in the military people because they do a strong push off. They always have a stress fracture in the neck of second metatarsal. The problem of this is it gives them pain on gait, and it always takes time to heal. Sometimes it's very prone to have non-healing. Jones fracture, when you look into the base of fifth metatarsal, very common injury. And the base of fifth metatarsal, as you understand, there is an apophysis if it's still young patient. If not, this is the tubercle where the brevis brevis attaches. Then this area is the articulation between fifth and fourth metatarsal base. Then after that is the shaft. Shaft fracture, we deal with it normally, just a flat shoes, keep it to heal. This one is a sort of avulsion injury, is very nicely healing once you relax the tendon. So we always, with this type of tuberosity fracture, we put the patient into a boot just to stop the brevis brevis from actioning. So it gives the fracture a good chance to heal. The problem is in this Jones fracture, where this fracture is in the metaphysio-diaphyseal zone, or just above the through the articulation between base of fourth and fifth metatarsal. And because this is a watershed area, is very prone to non-union, as you can see in this X-ray. And this is where we think about primary fixation rather than non-operative. Again, practically what we do, we just keep them on follow-up. We explain the patient that there is a high risk for this patient, for this fracture not to heal, because it's a watershed area, because of anatomy, because of biology. The vascular supply to this area is not the greatest, and there is a lot of stress on it while you weight bearing or doing gait. We put them in a boot, follow them up after 2 weeks, and if we feel that on consecutive follow-up it's not healing, we go and fix it for the patient. Sesamoid fracture, very commonly missed, and not everyone knows about it. I've seen it very few times. It's not that common injury, and we understand that the sesamoid is just a fulcrum inside flexor hallucis brevis tendon, They give it more line of pull, they give it more lever, so make it more efficient. At the same time, they protect underneath them the flexor, in between them the flexor hallucis longus. They are medial and lateral, or tibial and fibular. The medial is the tibial sesamoid, the lateral is the fibular sesamoid. They play a very important role in maintaining the hallux in place. If you miss one of the deltoid, one of the sesamoid, the other tendon will be pulling more strong, and this gets the hallux either in valgus if you miss the fibular, the tibial, and in varus if you miss the fibular. Very common to develop sesamoiditis, especially if a lot of stress, like the military people or people are walking all the time barefoot. In rheumatoid, in psoriatic patient, in Ray's disease or syndrome, this patient commonly to have a sesamoiditis, which will be presented as a blunter hallux pain. To see them, you have to do this view, which is called the sesamoid view or axial sesamoid view. And this gives you a clear picture of the sesamoid. This is the medial or tibial sesamoid, lateral or fibular sesamoid, and this is the crest. So you can see clearly the sesamoid metatarsal joint, and you can judge if there is any fracture or not. If you cannot spot a fracture, or you have a bipartite and you cannot decide this bipartite is a fracture or a bipartite sesamoid, this is the time you can have an MRI scan or bone scan. And bone scan will give you an idea, is it a hot or cold? If it's cold, so definitely a bipartite. If it's hot, it's mostly a fracture. Again, remember that we have an adductor hallucis here, abductor hallucis here, and the FHB, is running across the sesamoid. If you lose this medial, so the hallux will be going into valgus. If you lose this lateral or fibular, the hallux will be going into varus. So you're very keen to keep the two sesamoids, to keep the FHB efficient, so it doesn't allow the toe to deform in one way. If you have a sesamoid fracture, so it depends on if it's not badly comminuted and intra-articular, you can just put the patient in a stiff sole foot. In very rare condition, we go and fix it with a head screw. And at some stage, if we have no option, we have to do a sesamoidectomy. It's now only in reluctant patient, because recurrent patient and recurrent problems, sesamoiditis and recurrent and repeated fractures, because as I told you, sesamoidectomy will put the toe at a risk of going into varus or valgus according to what sesamoid you will be excising. Then, as I explained you, if you excise both sesamoids, so the loss of the FHB function. So the AHB will be taking or overpowering. This will end, but what we call the cock up toe. Then if we excise the tibial sesamoid, the toe will go into valgus. If we excise the fibular sesamoid, the toe will go into varus. Then if we have an injury sesamoid, we commonly to have this what we call the tariff toe. And if you know, and tariff toe is basically a hyperextension and axial loading injury to the hallux, end by this position, as you can see, where the hallux is just floating up with a flexed IB joint. Last thing to speak about is ingrowing toenail. It's not related directly to trauma, but since we are speaking about the toes, this is the last pathology we'll speak about. So basically, if we have an ingrowing toe, we understand that we go, nowadays we have the very good option is excising the wedge and just put a phenol to kill all the living tissues and the periosteum, and doesn't allow the nail to grow again. Otherwise, we can go for surgical Zosk's procedure, and this is when we go excise the whole thing, and just curate up to the periosteum, so it doesn't keep any germinal layer, doesn't allow the nail to go again. So this is the ZX procedure, but we normally use more excision of an angle, or excision of the nail wedge, and just phenolization to stop this from growing again. If you have in the exam puncture wound in the foot or puncture wound through the shoes, the commonest organism to do this to cause an infection in this condition will be the Pseudomonas. And remember, if you have that, you have to be keen on very good debridement, excision, removal of foreign body if it's there, taking very deep wound samples, and do a proper bony curettage if there is osteomyelitis, and definitely keep this wound open to clean itself. This small part is very common question in the exam. If you have, he come to you in the MCQ asking if you have a puncture wound in the foot, or puncture wound through the shoes. The shoes, what will be the most common organisms? The most common organism is Pseudomonas, and the most effective on it is Chinolones or Cipro. So if you have a foreign body in the foot, how will you manage that? So you manage this with aggressive debridement, foreign body removal, deep samples, and bone curettage, and keep the wound open to clean itself. And thank you so much. So any question, guys, just keep it in the chat, and I'll be happy to answer it. I try to make the lecture the shorter I can, so it's 10:15. So we still have 10 to 15 minutes. If you have any questions, I'll be more than happy to answer it. Next lecture is very, very interesting with all what you need to know about ankle fracture, both for the exam and for your day-to-day practice. I promise you of a very nice lecture, very fruitful lecture, a lot of new information. Though ankle fracture is very, very common, but the information I will give you in this lecture will be new information for you. As we always do, you will have a feedback link sent to you once we finish this session, and once you bought the feedback, you will be granted the certificate of attendance, and we are in the process of getting accreditation from the Royal College for that. So I'm waiting for any question. If you have any question for me, and hope you got something from this session. Rafat, thank you. You're welcome, Rafat, anytime. So guys, regarding after the foot and ankle, the next lecture is the last one, which will be next Friday. And I'm thinking about starting to give a reconstruction course. I'm not sure all of you know or not. I'm now the SS representative in the GCI, the Joint Committee of the Intercollegiate Examination. So I couldn't run any more courses about FRCS because I'll be part of the exam. So I don't have the I'm not permitted to give any courses, FRCS courses, but we can do any structural courses as general orthopedics. So I'm thinking about reconstruction as the next topic. If you have any comment about that, send it to me. All of you have my mobile number and my NHS email. So this is my number and my email, and I'll be welcoming all the suggestions about the next topic to go through. I'm just suggesting reconstruction. If you have any other topic you feel will be more useful to go through, I'm more than happy to do that. Okay, guys, if there is no question so far, I hope you digested this session nicely. Trauma is very interesting, and this is our day-to-day practice. I hope all of you get everything you need from this lecture. Waiting for your feedback. All your good and bad feedback will be taken on board and will be valued and will be actioned. And see you next Friday. Have a good evening and enjoy your weekend.